Welcome back to the second session on addressing social barriers in tuberculosis control. In our first session, we talked about many issues ranging from smoking and the vulnerability to TB. We talked about indoor air pollution, we talked about nutrition, we talked about lack of awareness, we talked about stigma and discrimination. Most often, many of these issues which we take for granted when we address a patient with TB, and we do not realize how important it is, not only in terms of vulnerability, but in also ensuring treatment completion and TB treatment outcomes. This session, I would really like to highlight alcohol and TB, because we have found from our many studies that there is a strong association between alcohol use and risk of TB. Not only TB, TB and HIV. Now, just to start with, how does it all start? Peer pressure, which is what really prompts patients to start with alcohol. Again, just alcohol, to overcome stress, family problems, depression, but it just continues. And this kind of alcohol abuse which we are talking about is what increases TB susceptibility. Why I say alcohol abuse, we are not talking about just a bottle of beer or once a week drinking. No, it is alcohol abuse that is measured by what WHO has a standard scale which is called the audit measurement. That is to measure alcohol use disorder. And we find that this measurement is important before we classify patients as those who have alcohol abuse and not just those who just consume alcohol. And what we have found is that not only does alcohol abuse, which I talked about, alcohol use disorder, result in vulnerability to TB, but it also has so many other repercussions, delays in diagnosis. It has an extended risk of transmission or infection. It results in treatment non-compliance, and also we find that it's one of the major causes for reinfection or relapse. So I'm going to just give you one of our study findings, which said that among the TB patients, 29% of them did consume alcohol. The default rate, look at the default rate, how high it was among this group of patients, almost 56%, treatment failure 57%. And like I said in the earlier slide, the different reasons that prompt people to reach that stage. But what I would like to impress upon you as doctors is that what patients go through when we just tell them things like, if you consume alcohol, you can die. If you consume alcohol, it's not going to go well with your drugs. These are kind of morbid messages, which result in them not coming back for treatment. So I think we need to be very tactful in how we talk about alcohol. You can't expect a patient who has an alcohol use disorder to overnight give up alcohol. At the same time, what we need to impress upon them is the need to continue their TB treatment and to be able to reduce alcohol. But when you say something like, you take alcohol and you take the TB drugs, you will die, the patient, when he has a drink, and a patient who has more than a drink every day would decide to just continue drinking and not coming for TB treatment. Some of the things which we have heard from patients is the doctor told us that every time I take alcohol and if I have to have my drugs, I would die. So that's why I've stopped going for treatment, because I keep taking alcohol. So I think as doctors, our kind of messages, not only doctors, even healthcare providers, the kind of messages that we need to tell our patients have to be so careful. So what does this all tell us? That there is need for alcohol intervention programs. We need to address alcohol use disorder. And to that end, we conducted this alcohol use intervention study. I would just like to share some of the things that we have done on what needs to be done for these people with alcohol use abuse. So what we did was a very community participatory approach intervention, where we first talked about what these patients wanted, whether they really needed an intervention, because as doctors, you all do realize that unless a patient is, in a willing state of mind, and he will not respond to any intervention, you can't force him to have an intervention. So here we had to ask them and their family whether they really needed an intervention. If so, what kind of intervention? So in this intervention, we found that we all talk it's I think kind of a well-known thing about the alcohol anonymous group sessions. We tried that, whether you need alcohol, group sessions. That's something that is very difficult in terms of TB patients, because you find that when they are sick or they come from different health centers, to have a group is different. So we had to go by an individual session. Individual sessions, what are the kind of intervention messages that we need? It had to come from them, where they needed more visual aids. They wanted to know what alcohol does to the symptom. What about TB and alcohol? What is the kind of reaction between the two? Why should they take treatment, as prescribed, and what would happen if they take alcohol? So it had to be a very different session with individual counseling that we had at 4 different time points. And this session really worked. If you look at the results, we found that there was almost an 87% favorable treatment outcomes among those in the intervention groups. And again, we found the treatment adherence was significantly higher among the group that had the intervention as compared to the group which did not have the intervention. And we find that there was a reduction in the audit score, and that means that even there was a reduction in the drinking pattern that we observe, which was significant again. So what does this tell us? That we need to have an alcohol intervention. Again, it is not easy for everyone to do an alcohol intervention. We need counselors, but when there are no counselors, doctors have to be equipped to at least give pertinent messages to the patients, so that we not only get them to keep taking their drugs, but also promote better treatment outcomes. So what we did through our study is we've come out with a manual, which we have it on our webpage. So any of you interested, please feel free to access this. Now, I just thought it would be interesting for doctors to know about TB among the tribal population, because there are very few studies on TB prevalence among the tribal population. Why the tribal population is because now, with the whole focus on elimination of TB, you find that we need to reach the unreached, and one such unreached group are the tribal population. We did a meta-analysis, and the pooled estimate prevalence of TB among the tribal population we found was very high, as high as 703 per 100,000. And here what was most a matter of concern was that there were so few studies and so much of heterogeneity among this population. If you look at that, anything from 146 per lakh to 3,294 per lakh. And what you doctors would find very interesting is there are certain tribes, especially a tribe in Madhya Pradesh, which are called the Saharias, where the prevalence was very high. So this kind of set us thinking that it was so important to do a study to estimate the burden of TB among the tribal population, and also to be able to gain insight into their healthcare seeking behavior patterns. So like I've already told you about the meta-analysis, here you find that most of the studies came from Madhya Pradesh, and here even there was a disparity. Very few studies from other regions. We had one from Tamil Nadu, we had one from Maharashtra, and all the rest were from Madhya Pradesh. So what we found through our study was some of the challenges that faced this tribal population. Major one, distances. The distances range from anywhere from, if you look at, to go to a anything from even 1 to 80 kilometers, 110 kilometers. How do you expect people in this difficult terrain to even reach any health facility? We found, yes, the concept of health sub-centers was there, but most of the places, these sub-centers which are supposed to be within 2 kilometer distance were closed and non-functional. We found a lot of structural barriers in terms of difficult terrain. If you look at the pictures there, some of the roads were so flooded that even our vehicle had to stop for almost 2 hours for it to clear. Long distances between healthcare facilities. And what we found is very few doctors are prepared to go and work in these difficult places. We found that patients had to be carried through mountainous hilly terrain on stretchers, and most often before they even reached a healthcare facility, they were not there anymore. So these kind of challenges kind of voices the need for more doctors to go and work in these kind of areas that really require care. We find that those who are there, the very poor attitude of healthcare providers there. One of the regions that we went in Himachal Pradesh, we found that a doctor here the one who posed to be a doctor was a pharmacist wearing a coat with a stethoscope and completely taken over the doctor's role. And there were patients, you know, who were just crowded all over there just to see him, all because they thought he's a doctor when he was not. So the whole image of doctors being taken by, and one can imagine the kind of damage that is being done to these patients. Again, we found that even for sputum collection, even for treatment initiation, sometimes they had to travel 60 to 70 kilometers. So what would really prompt these poor tribal people from even coming back to, you know, to be able to demand health care? Like I told you earlier, the sub-centers were closed. We also found that there would not even be any information about their results. So they would go there, there would be nobody to even tell them what their sputum results is. We found contact screening was practically nil in these tribal areas, and more so chemoprophylaxis. Like it must have been shared in our earlier presentations how important it is for contact screening, how important it is to initiate chemoprophylaxis for those below 5 years. This is just something that doesn't happen in tribal areas. And here we found that traditional healers have a big role to play, but their whole role is absolutely non-functional in these areas. And if one has to reach out to them, we have to go through these traditional faith healers. We found a lot of patient-related barriers which I have shared in my first session. Again, lack of awareness and misconceptions on TB. And apart from these different health, structural barriers, we found long waiting. Imagine traveling in such a difficult terrain and then practically spending the whole day at a healthcare center to be, you know, absolutely not even attended to in time. You know, and the communication we found was a major barrier because the tribal dialects are diverse. You know, the need to be able to have more tribal people involved even in healthcare, so that there is some kind of translation where, you know, these people could be better addressed. So the need doctors is very high in the tribal population. So through our study, what we found is the TB prevalence again was very high, especially in Madhya Pradesh. We found it was around 484 per 100,000 and the total was around 328 per 100,000. If you look, we found that while even Andamans was going in for elimination, but we find still it's a problem that has to, you know, be dealt with. Orissa, so most of the states except, if you notice, Maharashtra, the prevalence was pretty alarming. To summarize the findings of our tribal study, what we found is that the presumptive TB cases was as high as 4% among the tribal population, which is higher than the non-tribal population. Another matter of concern was almost 80% of symptomatics did not seek care, and among those who sought care, the most prominent symptom which made them seek care was loss of weight and blood in sputum, as compared to what we would think in terms of cough, you know, which did not feature. It came third, in fact. You know, it was first loss of weight and then blood and sputum followed by cough. And then here we find that the TB prevalence among the tribal population was 426 per 100,000, which is much higher than the general population. Another fact that I want you to open your eyes to is that TB prevalence was higher among the elderly population, and this has been also reported in non-tribal population, where sometimes you realize that this fact is kind of very often ignored. We always look at TB more among the productive group, 15 to 45. We do not realize that we need to look for TB even among the elderly population. In this group again, while most of them sought care from government facilities, we found that still even in the tribal areas, the role of private doctors has had a big role to play, in the sense more than 38% of them accessed private care facilities, and still we have traditional healers who have an influence on the health seeking behavior patterns. I would like to just present this very interesting slide which we did in Nicobar, because they were actually working towards a zero TB in this particular island, which is Hut Bay, that is in Nicobar. And we found that when we went there, we found there were about 3 MDR cases. We just went, it was just a village with 1,200 population. And looking at the secondary data, we were able to map out this, where if you notice the yellow shows that there was at least one patient in that house who had TB or a history of TB. So this is something that we need to think in terms of trying to, why do we need to do this? Because if in the program, like we are thinking in terms of active case finding, we need to have it more focused so we know where to. So even when we do our history taking as doctors, it is important to be able to find out the history of TB in the family, whether they are in contact with other patients, and try to see how best we can understand TB transmission dynamics and advise accordingly. So what are my key messages is that if we need to reduce the incidence of TB, we need to understand these drivers of the epidemic, which are where social determinants play a major role. We need to have a multidisciplinary approach, not only done by the health system, but also to be able to involve NGOs, to be involve other groups like NSS or youth, to be able to promote early detection and treatment. We need to have more of community awareness programs to increase awareness. So again, we are able to facilitate early diagnosis and treatment. And we need to think in terms of socio-behavioral issues, which are most often ignored by medical practitioners, if we need to have better treatment outcomes. So to summarize, we need to promote a holistic approach to deal with any disease, whether it be TB or TB and HIV. Thank you.